done a Doc Talk Live. I have Dr. Jeff Cantor with me, and I'm doing a remote from my office. He is in his office in Florida, in Fort Lauderdale area with Cantor Spine. Jeff, go ahead and introduce yourself and say hey to the Doc Talk Live audience.
How are you? Hi, Jeff Cantor here. Good
I
to have you.
appreciate you taking the time to speak with us today. A lot of times, Jeff, people see this on a replay. They don't necessarily see it live. So people tend to write in questions later. So hopefully Christy will get with your folks and make sure we get the questions answered. But Dr. Cantor, you're a spine surgeon, correct?
That is correct.
And you're going to talk to us about a technology that you use in the operating room, which involves ultrasound. Can you give us a little information about that?
Well, the normal premise that we normally work under in spine surgery is that we have bone spurs, disc herniations, and something that's pinching a nerve. The way we treat it is we have to get access to what's pinching the nerve and remove it. And normally, in the process of doing that, we have to take stuff out. With the traditional tools that we normally use, that the access, gaining the ability to get to what's causing the pain, we have to take things away that are structurally important. And what ultrasound has done, what the new ultrasonic bone cutters do, is they allow us to work in very, very small spaces. So getting access to the pinched nerves doesn't cause additional problems.
Can you show us the old cutter versus the ultrasound?
So what I have here is a traditional bone cutter, which is a drill. This is a traditional bone cutting drill. And what this is I don't know if you can see it or not, it's very similar to a Dremel. When you turn it on, it spins, it's sharp, and it's not something I'm going to touch near my fingers or touch my hand with. But when we put it on bone, what it does is it will dissolve the bone. And you can see it's got torque, it wants to move. The ultrasonic cutters use vibration. They're not sharp, they don't spin, and they use high-speed vibration to essentially pulverize the bone. They dissolve what's pinching the nerves. So the ultrasonic cutter is actually more powerful. It uses vibration, and also you can see there's a spray coming out of it, and that spray is coolant. It vibrates at about 22,000 times per second, so it's very, very fast. Kind of like if you rub your hands together very quickly, it'll generate heat. So the water coming out keeps it cool. And what we can do with it is we can very effectively cut right through bone faster than the drill, but we can do it in a way that's not going to damage the soft tissue like the nerve. So I'm going to put this on my fingers and turn it on, and it's very safe. And I can touch the spinal cord, I can touch nerves in the same way.
Why is it called ultrasound? What is ultrasound about it?
Ultra is exceptionally high, ultra high speed. Ultrasound is using vibration. So it's the same basic technology that we use in ultrasound imaging. It uses vibration to generate a wave pattern, a force that can be used for picking up images. It can be used for cutting. It's just a very effective way of generating energy in a very safe way.
Why isn't everybody using this tool?
It takes time to learn. This is something that's really catching on. Right now, probably about a third of the doctors in the country are starting to play with it. I had an injury about 8 years ago. I fell off a bike and broke my wrist. And in that process, I had my arm in a cast for about 3 months. And I couldn't operate. And I've always wanted to learn how to do this. I was playing with it, but really wasn't at the point where I can really master the skill. So I went upstairs to our lab. Actually, these tools we have here are the tools that we have in our lab. So I was able to practice on models first and then cadavers, 3D imaging, and we used a whole bunch of systems to really perfect the technique. And interestingly, one of the individuals up in our lab was one of the investors in Mako Robotics. Mako was developed here. Mako Robot was actually developed in this building. And one of the investors was there, and he kept on watching me, and he said, my father is in Boston. He's scheduled to have surgery at Mass General, and I've been watching you practice this, and can you do this to my father? And I said, well, I've actually never done this to a person, that's live. I've done it in cadavers. He said, well, you've spent more time practicing than anybody has done in other techniques. So when you start doing this, I want you to my dad is somebody I want you to do this on. So he was the first one that I did. And that was about 8 years ago. So this takes time to learn. It's a powerful tool. It's actually more powerful than the drill. It has fluid, so it kind of looks like spinal fluid. So a lot of doctors aren't comfortable working with that fluid in the area. It's very powerful. It cuts very, very quickly. So you have to kind of plan your surgery much differently. So the operation, instead of making a hole and kind of looking around, all of our cuts are planned in advance. We have whiteboards and we have programs that actually plan exactly where we're going to make our cuts versus the old type of surgeries. We make a hole, we start thinking as we go. This is a much more precise, much less invasive technique.
I'm interested in that. It's what what else interests me is that you see all this marketing, at least in Alabama, I do on robotic spine. Using robots to help aid your surgery, but this actually seems like something that replaces old technology that is really a much more marked advance than robots putting screws in the back.
Well, what this does is, quite frankly, this is what is going to be strapped on the end of a robot. So ultrasonics and this type of technology ultimately will be the business end of a robot cutting device. So a robot that is using a device like this, I don't care how precise the robot is, you're not going to put that next to something that's delicate. So I'm not going to touch this tool to my finger. A ultrasonic device we can use with image guidance and with robotic guidance to actually get inside the spine and very precisely work in small spaces. So I can work right between my fingers without injuring my fingers. So we can work in tiny, tiny spaces, and because of that, we can really change the whole way spinal surgery is done.
Can you show us a case where and show us how you map it out? If you could, how you look at the problem prior to surgery and how you plan your dive and how that dive looks. Can you show us some images?
Well, actually, I don't have something like that loaded. What we would normally have is a CAT scan, and the CAT scan can give us accurate measurements of where we're going to cut.
Okay.
So I don't have that loaded on the program right now.
Okay.
I can load one. It'll take me a few minutes to do that, but I do have some examples of different types of surgery that we do. So I can go over a couple neck operations, and I can go over some lumbar surgeries and really show the difference in how this really changes the whole paradigm.
Okay, give me one sec. Oh, there we go. So I'm just trying to see if questions are popping up. There's sometimes a delay. Does this procedure have application to scoliosis or flat back syndrome?
Yes, it does.
Okay.
Are
the surgical outcomes improved with this procedure?
So the first question was, does this apply to scoliosis? And the answer is absolutely yes. Most of the scoliosis surgeons nationally are starting to adopt this technology because it makes much more precise cuts.
Okay.
So with the new image guidance systems, we can plan surgeries better, and with these systems, we can make exact, accurate, what's called osteotomies and cuts. And in the flat back deformity space, it applies in the same way. So my partner, Dr. John Ashgar, and Dr. David Feldman in Palm Beach also uses ultrasonics. Dr. Ashgar has been with me now for about 2 years, and he moved his practice to adopt the ultrasonic technique. So in the scoliosis space, it's really catching on fast because of the accuracy. It's faster, it's less blood loss. It's a much, much different operation. So it applies to deformity surgery. And flat back is also deformity surgery. We're trying to take somebody with a abnormal curve in their back and rebuild a more compatible curve, and that also is something that this tool does exceptionally well. This tool does every type of spine surgery better than the traditional tools. And what's important to know is it's not the tool doing the procedure. The ultrasonic technology facilitates a different type of procedure. It doesn't do the operation. So what this allows us to do is to plan differently. It allows us to save normal structure. So we don't have to remove things that are important. We don't have to rebuild them. So with traditional tools, we have to make big holes, big incisions, take out a lot of stuff that's important to hold us up. And when we take something out that's structurally important, we have to rebuild it. And that's with screws and rods and all kinds of things. If we don't take it out, we don't have to rebuild it. And I have some examples to show you how that all works.
Let's see that. Let's see that. That's perfect.
This is an actual image of an ultrasonic tool cutting. This is a tiny incision. We're working in an area about that big. So this is highly magnified. You can see the size of this tool is about like that compared to what we're looking at here.
Now, are you in the neck or the lumbar spine?
This is actually a lumbar spine, but it works the same in both areas.
Okay.
So what you can see here is this is cutting through solid bone that quickly. And underneath that, you're going to see in a second, there's going to be an area where you're going to see blue. So we're in contact. We're touching the nerve and cutting the bone. You can't do that with a drill. It's physically touching the delicate structure. So we're going to move away what was pinching the nerve and pinching the nerve, and underneath it you can see the nerve with no remaining pressure.
Did you just pull out disc there?
This is actually bone that we've created. We turned the bone into dust, and we're just sucking out what we've created.
Okay.
What that used to be is an area that's being pinched by the nerves. Now, this is going into cervical spine. This is a photograph of a X-ray of what's called a flexion extension view. And what this shows is how much, when you flex and extend, the neck really moves. So the problem in the neck is the most mobile joint structure in our body, but it also has in it a very delicate nerve called the spinal cord. So your brain is here.
Right.
The bones in the neck are these structures here, and the spinal cord is this black cable surrounded by this white. And this white is spinal fluid. The spinal fluid protects the spinal cord.
Can you blow it up for our audience? Because I know your camera can't get closer. Can you blow up that image at all?
I cannot. So
That's
if we
fine.
want to just take the camera off and get a little bit close,er I can show you.
Go ahead and do that.
It may shake a little bit, but we can probably see it better. Pop it out of there. Hang on. Got it? So if you want to look closely, the brain, here's the base of the skull, the bottom of the skull. The brain is anything above that. The spinal cord is this structure here.
And it is totally pinched there at C34, C45.
Correct. Below there it's good. Above there it's good. So the middle section here is pretty severely compressed.
Yep.
So clearly you can see around the cord is water, space. So around the spinal cord is plenty of room. Here what we have is bone growing into the cord and pinching the nerves. And the way we fix this is we have to take something out. We have to either remove what's in the front and move that out of the way, or remove what's in the back and get that out of the way. But the bottom line is we need to rebuild this channel. With traditional tools, we have to take enough out where we have to structurally rebuild it. So that looks kind of like this. So using the traditional techniques, we have to do multiple level fusions, which, by the way, isn't a terrible operation. It's a good operation in many cases. The problem with doing multiple level fusions is it creates stiffness. And when we take all these individual bones and we fuse them all together and make this solid, it takes all the motion away and transfers the motion above and below. And when it does that, those joints are going to wear out. Another way of doing that is from the back of the neck, where we do what's called a laminectomy and fusion with screws and instrumentation, screws and rods. Now, this is about a 10-inch incision. It's a massive operation, and I used to teach this operation. I stopped doing it because a lot of the patients who had this surgery after a couple of years said they really are not happy with the results. They've lost a lot of motion. They kind of wish that they had never done it because of the comorbidities, the problems that they've had subsequent. So this is a massive incision, massive operation. You can't take it back. Using the ultrasonic technique, we can fix the same problem through an incision, and that's my finger. So the incision size is about that big versus 10 inches. And we can deliver a product that looks like this. And this is bones that have been completely reshaped and hollowed out with no screws, no rods, and no fusions. And the reason we didn't have to fuse is because we didn't take out the normal structures that hold the head up. So when we take the cable systems out that hold the head up, we need to rebuild it with screws and rods. If we don't take the cables out, which is facilitated by these new technologies, we can work through tiny holes underneath the important stuff and not have to remove it. And then we can deliver a product that's much more compatible with a normal lifestyle.
What did you take out there? So it's missing spinous processes. I guess you took out some lamina. What did you remove?
Okay, I'll show you that. I'll do that real briefly in a second. But this is going back to fusions. The problem with fusions is when we do a fusion and these two bones are fused together, and within 5 years after doing this, the problem from the stress transfer above, now you've got the stenosis at 2 additional levels above. So the fusion transferred stress and recreated the same problem again. So when you do multiple level fusions, you're going to be back doing them again with a high probability. And this is example after example of that same thing. Again, multiple level fusion with stenosis above. This is an individual with a 1-level fusion 10 years ago, now has had 4 fusions, all because of stress transfer. So what this tool does, and let me go to a video of an actual operation, is what we're doing here. This is using an ultrasonic tool, and we're basically hollowing out the bone, and we're working underneath the cable systems. And if you look here, you can see, it's kind of hard to see, but this area here where the bone is still attached to the cables, it's still left attached to the bone. And because we're not taking that cable out, once again, we don't have to rebuild it.
So
So
you're kind of shaving underneath the lamina?
we're just dissolving inside the lamina what's pinching a nerve and saving the lamina. So
That
rather
is
than taking
clever.
it off, we're hollowing it out.
I got it. And
Like
because the tool is so
precise.
cautious around the spinal cord, it doesn't injure it.
So this picture shows the tool actually cutting that bone out, and the spinal cord is right below it. So we can touch the spinal cord, and you can see it just dissolves the bone. And rather than a spinning tool that will tear, and you can't do this, it's just not possible. So you have to make a much bigger hole. Then
So
what we do
this is
is
going in from the back, I take it.
correct. And what we're doing here is we're taking the covers or the lamina, and this is a different part of the process. And what we can see here is the cover. This area here, this part is the cover of the spinal cord. And what we're going to do is we're going to cut the bone here, make so we can actually lift this up like a drawbridge, and then we're going to make the channel bigger plastically. And by working underneath the bones above and below it, we can do this in a way where we don't need any screws or any rods or any fusions. So what this shows is the tool cuts the bone and we don't actually ever touch the nerves. Now the bone is so thin I can bend it. And then what we're going to do is take little spacers. And by the way, notice how small the incision is. This is my fingers in front of the incision. It's about 1.5 inches
Okay.
versus about 10 inches. So we're going to take a little hook. We're going to take those bones that we have sculpted and reshaped. We're going to lift them up, put a shim in, and it's kind of like opening up a drawbridge and then putting a piece of structure in to hold the drawbridge in place. So what we've done essentially is just rebuilt the spinal channel in a way this will just regrow, and now the bones are just bigger. So instead of having stenosis, the spinal canal is bigger than it was when you're born.
Okay.
So
So that shim is like a bone dowel.
that shim is in fact a bone dowel, and this is the newer technique showing saving the cables you can see the spinal cord that was pinched before is now completely open. So the area where the cord before was compressed, all that stuff has been moved out of the way, and now the spinal canal is open, bigger than it is normally. So here's the cord, and you can actually see the area where the cord damage was before. So this gives almost normal motion, no fusions, quicker healing, less blood loss, no comparison. So this is a picture of a patient before surgery. Same patient after surgery, completely rebuilt, has been able to resume completely normal activities with a 6-level neck decompression, as opposed to a neck that won't move again.
Somebody wrote in, how many surgeries have you done using this technology? I would imagine too numerous to count, but go ahead and
probably close to 3,000.
Yeah, that's
probably got about close to 10,000 hours using this tool.
And what's interesting is most everybody approaches the neck from the front. You know, years ago they used to approach it from the back, then it went to the front. Now this technology is bringing it to the back again.
Well, it's both. What our goal when we do an operation is to save everything that still works. So when you do procedures from the front alone or from the back alone, you're going to find situations where you can't get the job done. So when you're evaluating a case, what you have to look at is, okay, what still works? So if I'm looking at this case, the patient, this individual has multiple level, you can't see here it's on a regular x-ray, but multiple level areas where the cord is compressed. So from C2 all the way to C7, the cord is compressed. What's important is if you see this bump back here, that attaches to a cable in the back of your head. Now if you feel that bump go down, you're going to feel soft and it goes to another bump. Well, that's the second bump. That's the ligament that holds your head up. That's very important because if you take that out, you have to put screws in. If you work through a small incision under it and don't disturb that, you don't have to use screws. So in certain cases, we can do the procedure ideally just from the back. And this is for multiple level. This isn't for a single disc herniation. This is for somebody who has multiple level severe cervical stenosis. Extremely important in younger people. Works for everybody. But if you take somebody who is 35, 40, 50, 60 years old with cervical stenosis, and they have this procedure, the redo rate is less than 1% at 15 years versus almost 30% per year with a 4 or 5 level fusion. So the chance of needing another operation in a younger person is very small compared to the traditional fusions where you're very likely going to need multiple additional surgeries in your lifetime. So going back to what we were talking about before, our goal is we want to save that cable. In addition, there's certain areas that we need to be able to get access to. So in the center of the spine, when the cord is compressed, going from the back is very effective. But when the nerves are pinched off to the side, you sometimes have to go from the front. So every once in a while, we'll do a procedure where we'll do a laminoplasty and we'll combine it with a 1 or 2 level fusion in the front, which will be a 1 or 2 level fusion versus a 6 level fusion, which will be able to preserve everything that's still structurally important and still works, not cause any damage during the surgery, and preserve almost normal mobility versus compromising mobility. So we do hybridize. We combine operations. It's a much better way of approaching it as opposed to saying, well, you've got 6 different problems and we're going to treat them all the same way and we're going to throw the baby out with the bathwater. What we're going to do is address each individual problem specifically for that problem. And just because one problem creates a situation where it damages, to fix that is going to create damage to another level, we're not going to do that at the other level that's going to cause that damage. We're going to change the operation. So in one patient, we may do 5 different techniques.
It seems like in the neck, like if you had a herniated disc at C4-5, that C5 nerve is really sort of susceptible to injury more than the other nerves. Have you noticed that the C5 nerve injury, deltoid weakness from, let's say, an ACF at C4-5 seems to be a little bit, that nerve seems to be a little bit more at risk?
Absolutely. And there's a couple nerves in the body that don't even like to be looked at. And the C5 nerve is one of the nerves where just manipulating and changing its position can cause the nerve to shut down. So there's certain nerves in the body that if you have nerve compression, the C7 nerve that controls the tricep, a lot of people have really severe tricep weakness and don't even know it. I mean, the tricep, if you're not doing a push-up, you don't know that it's weak. The C5 nerve is what allows you to feed yourself and bring your arm over your head to comb your hair. And it's a very, very delicate nerve. So C5 nerve injuries are more urgent. So if you've got a tricep that's not working, you want to try some simple things, epidurals, time, that's fine. Once your deltoid starts going out, it's something that you really need to pay a lot of attention to. Not all of them need surgery, and a lot of them don't need surgery, but you've got to really be in the hands of somebody that is comfortable with that and familiar with what the implications are if that's not treated quickly.
Does the
Also,
ultrasound help you, let's say, uh, with that nerve in terms of can't surgery cause injury to that nerve?
the ultrasonic technique is much better. In other words, when we take pressure off nerves from the front of the spine, we're doing fusions or disc replacements. The ultrasonic technique allows us to get much closer to the delicate structure so we can really clean the pressure off the nerve. So when a nerve is pinched, we need to open it. We need to get the nerve so it moves again and so the nerve is no longer compressed. With the traditional techniques, it's very difficult to get that close to the nerves without damaging them. So it's possible when you're done to still have pressure on the nerves. There's structures in the neck, very important blood vessels. One's called the vertebral artery that is right near where the nerves are compressed in the neck. And when you're trying to clean the pressure off the nerve and you're near that artery, you get a little bit of chest pain as a surgeon getting that close to that structure because that can be a very dangerous problem if you damage that blood vessel. With the ultrasonic technique, we literally can dissolve the bone off the nerve and the blood vessel safely so we can see that nerve go all the way out and completely clear much faster, much safer, much less blood loss, completely different paradigm. So, like I said, I can take this tool and I can work right on the nerve and touch it, and I can do it very safely. I can't do that with a drill, and with the traditional Kerrisons and normal spine tools, you can't safely get that close to a nerve and clean a bone spur off. Also in revision surgery, we're doing patients that have previously had a fusion or had another operation, scar tissue just dissolves with the ultrasonic techniques. With the other techniques, it's very risky with dural tears and nerve injuries. With these newer tools, we literally can just melt the stuff right off the nerves, even as fast as we can do a case that hasn't had previous surgery. So it's a total game changer.
It's amazing. So I'm just, I don't know if this technology is in Birmingham yet or if surgeons use it or not. You said about a third of surgeons are using this technology.
Most of the deformity surgeons, the scoliosis doctors, are using it a lot.
Okay.
A lot of the academic-based deformity surgeons are starting to use this. They're not doing the decompressions a lot because they really haven't had the opportunity to practice. This technique is something you have to work on. It's not when you're going inside the spine and you're working in the channel where the nerves are. So when we're doing these procedures, we're actually not, normally what we do is, by the way, I have a model in that room. Give me 1 second, I want to show you something.
We're taking a break. If anybody has any questions, type away. If anybody's watching.
So here's a model of a lumbar spine, and what we normally do is we take these covers off. They're completely gone, and we can see inside.
Right.
With the ultrasonic technique, we don't do that. What we do is we work through little windows, and the operation is done inside and underneath, saving all of these. So that takes a very different approach to doing the procedure. We're in an area that you really can't see well. It needs to be thought out and measured in advance. And that's what I use the image guidance for. And actually, I played around the first couple months when I was using this in the laboratory with image guidance systems and developed techniques where I can actually use the same process that I use the image guidance, and I can actually do it faster by memory. So I can look at a CAT scan and an MRI scan in my mind, develop where things are, and I can go in and clean the pressure off the nerves quicker than we can use the image guidance system.
Jeff, I would love to see either a live surgery with you one of these days, or something where you've planned it out and show us how you get underneath the bone. I think that's fascinating. Somebody has written in, where are you located? Go ahead and tell our audience where you're at, Jeff.
Well, we're in Fort Lauderdale, Florida. We have a second office in Palm Beach, Florida. Our office is called the Cantor Spine Center at the Paley Institute. We're a member of the Paley group, and the Paley group is centered in Palm Beach. I see patients primarily in Fort Lauderdale, but starting in April, I'm going to be seeing patients in Palm Beach as well. The other associates, the other spine surgeons in the group, also see patients in Palm Beach and Fort Lauderdale.
But I would imagine patients fly in from all over the country to see you, and obviously Dr. Paley as well. But I would imagine people fly in and fly out. How long do they have to stay there if they do fly in?
Well, it's interesting you said that, because this coronavirus today, I think I canceled half my schedule. All the patients from out of state or out of the country canceled, so I had pretty empty schedule.
Timing. I got you at a good time.
Everybody's canceling, so it depends on what we're doing. Operations can be within 4 or 5 days. They can travel for up to 2 to 3 weeks, depending on how complex the problem is. If you have a simple stenosis operation, before I spoke to you, I was speaking to a gentleman from Trinidad who's flying in. He'll get all of his clearances here. It takes about 3 days. We'll do the surgery, and he'll go back in about 7 days after that. A simple discectomy, which we do have people travel long distances for discectomies. Last week, I did 2 discectomies from out of the state. Typically, it's about 4 to 5 days, and then they can travel. We like to be responsible for our stuff. I don't want you to have a surgery and then go somewhere else where nobody really cares as much about it as we do. So we want to make sure before you travel, everything is stable, the wounds look good, you clearly understand what's going on.
So we have a viewer who, and I'm going to try to answer this question first. But one of our viewers says, cool, thanks. This technique he is describing for nerve relief is called what? And I would answer that question by saying that you are using a ultrasound technology, which is getting rid of tissue while not putting the nerves at risk, and is sparing tissues so that the patient can recover better. That's the way I would describe it. If somebody were to Google this and say, hey, I want somebody who does this type of surgery, what would they put in their search engine?
Well, there's not a lot of it out there. This is called a lumbar laminoplasty or ultrasonic laminoplasties. You're really not going to find a lot of this online. This is new stuff. I was recently just invited to 2 major universities to teach this. One of the cancer tumor surgeons that used to be the head of the tumor department at Mass General is now at UCLA, who recently invited me to come to UCLA to teach the doctors there these new techniques. And this is fascinating stuff. This is where spine surgery is going. Everybody is going to be using this over time. It's just a matter of getting comfortable with it. It's so different. It's a totally new technique. It's kind of like telling a golfer, okay, you're doing really well with this particular club, but I've got a club that works really differently. Once you learn how to use it, you're gonna play better. But it takes a couple months to learn how to use it. And also, what's interesting about this tool is the operations are so much smaller. Economically, it doesn't make sense because you're doing a smaller procedure. The reimbursements tend to be lower. So it's not something that it's difficult to say, take a couple hundred hours to learn something that potentially might impact the way your business. So I think that the Cantor Spine Center, cantorspine.com, is probably where you can learn most about this. There's a few doctors nationally that are starting to do some of this stuff, but as far as the decompression work, there's not a lot of it out there. It's really in its early stages of being spread.
Have you ever seen your partner, who I trained, Anthony Giaffreda, do a cervical transforaminal epidural?
No, I have not, but I can tell you that that you've done a great job training Dr. Giaffreda. He's phenomenal.
But anyway, I would
So
take a look
technically,
at
he does a
that
beautiful job.
because that approach, that needle-driven approach, may be something that you could use to do a foraminotomy through the front with precision guidance. I don't know. You'd have to see the way he does it to see whether or not there is some cross-pollination that you could apply with this technology for minimally invasive treatment.
Well, there's a lot of cross-pollination. Dr. G and I, we talk on a regular basis and review cases on a regular basis. The intercept procedure that he's doing is fascinating. I think it's probably another technology that really is, I think, going to change the way spine surgery is done. This ultrasonic technology is changing and will completely change the way spine surgery is done in the future. And like I said, robotics, the more precise that we can get, the less we have to actually see inside, as far as doing framinotomies using a needle tip on a tool like this and having image guidance that we can get to the place that we want to go safely is things that we are working on. But the robotics, we're a couple years down the road before we're really going to be able to apply that because of there's a lot of logistic challenges with marrying the cutting tools with the robotic tools. The robotic tools right now are very effective at putting screws in, but my whole goal is to try to not use the screws. These techniques that we use are designed to eliminate fusions, decrease fusions, eliminate screws and rods. So our whole practice is really designed around how can we preserve structure, function, and mobility and avoid doing things that compromise folks' mobility. So 100% agree that when we cross-pollinate different subspecialties, we come up with good ideas. And the more we talk to each other, the smarter we get.
Is there a website folks can check out? I'm sure we'll post it later, but is there a website for y'all?
I think, Christy, will put the Cantor Spine Institute. I think it's cantorspine.com. The Paley Institute website also doesn't have all this stuff up yet. That's been a new merger. So cantorspine.com. And just look Jeff Cantor, ultrasonic spine. You'll be able to find.
Yeah, and you've got YouTube videos out there. I've seen some of your YouTube videos, which are excellent, showing this technology and how it's a game changer. So I want to thank you. If we can ever get in the OR with you, I understand there's a lot of anxiety around HIPAA and this and that and breaking new ground, but you like to break new ground. I like to break new ground. So the more we can show our audience stuff live, I think the better. And hopefully we can grow this medium so that more people can tune in and ask questions while we have experts here. I'm going to take, Tyler has been typing in this whole time, so I was just about to say goodbye, but I just want to say what Tyler says. My mother had a C1 laminectomy and a small portion of the base of her skull removed for Chiari release. However, I think she may also be suffering from some remaining nerve compression in her cervical spine. Seems like a great thing to explore. Thanks very much for sharing. I think that's a good, I think she nailed it, right?
Absolutely. I think first of all, this is a very effective way of doing Chiari releases. And a lot of the neurosurgeons are starting to do that technique, use this tool for that technique. It's a lot safer to work around the base of the brain with the ultrasonic tool. So it's possible that if she had a Chiari release, she may have stenosis down below that. And if that's the case, then this certainly would apply.
Well, I want to thank you again, Jeff. And
Brad, thank you.
Great talk.
Appreciate
I appreciate it.
Thanks.
All right, I guess I'll sign off. This is new technology to me. This is the first time I've used this Be Live, so I'm going to just hit stop. Stop stream.